Welcome. My name is Martin Drost. I'm a faculty member at the University of Florida Veterinary College. I'm also a diplomat in the American College of Periodontologists. Periodontologists are veterinary specialists in reproduction. And that's what I do. My specialty area is bovine reproduction. I teach in this area in the professional curriculum, and I visit farms. I go to and have cases come into the clinic, and my research effort is also in that area. We work on cycle control and programmed breeding. We do a lot of work with the effect of heat stress on fertility, and I'm involved in reproductive technology. Well, today I'll talk then about bovine reproduction, and we'll use the cow as a model. She's an excellent model because she has a regular cycle. She cycles every 21 days. She cycles all year long. And we have the unique advantage that we can examine the reproductive tract directly. We can actually feel the reproductive organs, and we can monitor her reproductive activity, her reproductive status. And here, a familiar picture, I hope, a reproductive tract obtained at the slaughterhouse, which is another advantage of using cows. We can go to the slaughterhouse and obtain specimens in all stages of development for the teaching program. I would call attention to the arrow at the uterine body. That is also the site of deposition for semen. I'll come back to at a later point. And the broad ligament, the ligament that suspends the entire tract, the mesometrium, the mesovarium, and the mesosalpinx that supports the oviduct. Now, the broad ligament is the one we use to retract the uterus into the pelvic area so we can examine the uterus more closely, and we'll come to that. Here is a picture highlighting the ovarian bursa. The fingers are actually in the bursa, and we can do that if the rectum of the cow is relaxed enough. We can actually do that and examine for the absence of adhesions or the presence, and examine the oviduct itself. If there is perhaps dissension of the oviduct, hygrosalpinx, things of that nature. That's not a routine manipulation, but we can do that. I want to focus a bit on the ester cycle. As I said, it's 21 days long, and we can monitor this from day to day almost, but most specifically around the time of estrus. Day 0 is the first day of estrus, and you recognize here a large follicle on the ovary on the left, the larger one, and that's characteristic of estrus. It's the ovulatory follicle. There are no corpus in the upper panel at the right. You can see an old corpus luteum that is kind of pale yellow that has regressed. It's one of the previous cycle, but it's no longer active. So the predominant hormone here is estrogen. We can monitor this by palpating the ovaries directly per rectum, or we can monitor them by ultrasound. And you see how nicely these follicles particularly show up on the monitor. Now here we see day 2 of the cycle. When the follicle has ovulated, it leaves a crater, which we can also actually palpate. It fills with a blood clot, and from it develops the corpus hemorrhagicum, as is shown here. It's not particularly echogenic yet. It's small. It is soft. On day 7, the corpus luteum has attained maturity. It's at its greatest size, probably 15, 18 millimeters in diameter. It feels actually like a piece of raw liver. And at this point, it is also mature, where it can respond to the actions of prostaglandin F2 alpha that's produced by the uterus at the end of the cycle to regress the corpus luteum and diminish the progesterone concentration and initiate a new cycle. When the progesterone goes down, then the follicles can deploy, grow quickly, and become ready for ovulation. I need to point out a special structure. I call it a hollow corpus luteum, rather than in the literature a cystic corpus luteum. I think the term cystic is misleading. We'll talk about cystic ovaries in a moment. But hollow corpusculia have a fluid-filled space in them, as indicated by the arrow, and they can be visualized very nicely with ultrasonography. Palpation is a challenge because the corpus luteum is thick and much rounder than usual, plumper than usual, but you can't be sure. You can suspect that they are fluid-filled. But it doesn't matter because these corpora lutea are normal in their function. They have enough luteal tissue that they will regress at the appropriate time. They will support a pregnancy, all of that. So they do not require treatment. They are normal structures. And it's with ultrasonography that we've realized how common this feature really is. Well, the cow is also nice as a model in its estrus behavior. She is unique in that she is truly bisexual. Cows mount other cows, bulls mount other bulls, and bulls mount cows. And this is very fortunate because it gives an indication of when the cow is in heat, which is very helpful in a breeding program. I remember even as a kid on small farms, when a cow was mounted, we would then walk her to the neighbor to have her bred by a bull there. But I would wonder here, what would have happened to the artificial insemination industry if it hadn't been for the fact that we could readily determine when the cow is in heat and when she would be ready for insemination. In this scene, we see the cow that is standing. She is the one that's truly in heat. The other is just sexually active, and this tends to occur as a group activity. Those that are near estrus will congregate and will point each other out, if you will. And that's what they do in nature. They point the cow out to the bull, and that's his visual cue to and clue to check her out and breed her. Heat detection is an extremely important part of a breeding program because we need to know the specific time. We can't be there all the time to detect estrus, and we use, for that reason, various heat detection aids. And this cow is wearing a small white patch in the middle of her back that is pressure sensitive. It has a capsule of red ink in it, and when sustained pressure is put on that, it will spread inside the capsule, and she has a red mark on her, which the owner or the herdsman can see, and then line this cow up for insemination. There are other kinds of patches. There is currently a heat watch, a commercial name for a large electronic patch, which is fantastic because it's whenever the cow is mounted, the electronic signal is sent to the computer, and we can follow exactly how frequently she is mounted. And the computer keeps track of when this first happened, so the timing is accurate. The number of the cow is recorded. A very nice system. Unfortunately, it is somewhat expensive, and will take some time before it's generally used. We also use teaser animals. I show you one example, a bull that has undergone surgery to displace his penis off to the side for at about 45 degrees, so he can no longer make contact with the cow. That is, he cannot intromit, and that's an advantage because we don't want to breed to an average, genetically speaking, bull, but we also do not want to transmit venereal diseases, things like campylobacteriosis or trichomoniasis. These bull, it doesn't show real clearly, is where this bull is wearing a gin ball marking harness, a gigantic ballpoint pen under his chin, so he leaves marks on the animal, and we can then tell that she was mounted. We don't have to use bulls. We can also use cows that are androgenized, that are treated with testosterone, and they'll perform in the same manner. Of course, those are also not capable then of transmitting venereal disease. Or steers that are treated with testosterone to give them libido again. We can monitor the accuracy of the heat detection program on the farm by collecting either blood samples or milk samples, and milk samples are easier to collect for the dairyman, and then run them, usually retrospectively, for the content of progesterone to see that progesterone truly was low, as it should be during estrus. Corpus luteum is not functional at that time, and check the accuracy. A number of large studies has been done in this regard, and on most farms, about 20% of cows are submitted for insemination that are not truly in estrus, that have elevated progesterone levels. It helps explain our success rate or the lack of success. Well, let's assume we have inseminated the cow successfully, but we need to prove that indeed she conceived, and if not, we need to give her another opportunity to. The most common method of pregnancy diagnosis is per rectum, palpating the uterus directly, and the early signs are that of asymmetry and of fluctuation, the presence of fluid. But those are not positive signs. Asymmetry is actually a residual after a cow's been pregnant. Her previously gravid horn is not totally back to the original size. And fluctuation could also be due to the presence of fluid or pus. I have pyometra, cases of hygrometra, pretty rare, and mucometra. So those are suggestive, and we must prove that then by slipping membranes. We specifically slip the outer fetal membrane, the chorioallantoic membrane, as is illustrated in the picture right here. Picking up a fold of uterus, a rather large fold, and then letting the contents slipping through the fingers. And the slip is felt while we still hold on to the uterus. It's not slipping off the edge of the uterus. Here's another illustration of it where the uterus has been cut open to show how the membranes are gathered up by the fingers. The next sign, chronologically, is the amniotic vesicle, as illustrated here. That can be picked up as early as 35 days in the cow. It will be the size of a pea, about 7 millimeters or so. And then it grows really on a daily basis. And the experienced palpator can follow that and can recognize that and say the size is, say, 15 millimeters, which would correspond to 42 days. It's 35 at 48 days, and so on. There's a scale for this. It can be used very accurately within a day or two by the experienced palpator. It takes practice to locate the amniotic vesicle. It's kind of like when you're taking a shower and you're trying to pick up a fancy oval bar of soap off the floor. You can't just pick it up with thumb and finger. You have to surround it. You have to trap it. And that's what's illustrated here. Trapping this oval vesicle. It will be fairly turgid. But let me voice a word of caution here that we can traumatize this vesicle. It won't rupture necessarily. Of course, one can do that on purpose. In fact, in the feedlot, sometimes they cause abortion therapeutically that way. Feedlot heifers, they don't want pregnant, they pop the vesicle. Can be done. Not too easily done by accident. But what you can do readily is disturb the blood supply, as is illustrated here. The delicate vesicles blood vessels rather, can break away from the vesicle, and the embryo then has no blood supply and will succumb. She's not going to come back in heat right away. Our colleagues, Dr. Bondurant in California, did a study once and found when they disturb the vesicle, it takes 2, sometimes 3 weeks before the cow returns to a cycle. So it's possible that early palpation particularly to cause damage. It may be advisable not to palpate cows until about 6 weeks, 42 days, 45 days. Doing it earlier has the disadvantage of trauma, and it's also still a period during which spontaneous, whether we palpate or not, spontaneous early embryonic death occurs. After the vesicle has grown and becomes larger, it also becomes softer. We can no longer outline this with our fingers, but we can start feeling within the vesicle a small fetus. And this first is possible at 60 days, at 2 months. At 2 months, the little fetus is the size of a mouse. And it increases then every month to where at 3 months it's the size of a rat, and at 4 months a small cat, at 5 months a large cat, a big tomcat, and then at 6 months about the size of a medium-sized dog, like a beagle. So we can follow that. And it has value to know how to do that, because if a farmer finds a fetus, an aborted fetus, in the barnyard or out in the pasture, it's important to know about what stage of abortion this was. Abortion diseases act at the various diseases at different stages of gestation, be it in the first trimester, the second, or the third trimester. So it's helpful to have a little point of reference. After the fetus, we also have access to caruncles. I should really say placentomes, the caruncle plus the cotyledon, the fetal component. We can palpate these placentomes, and we may take this as a positive sign of pregnancy, which they are. There is about a total of 120 of these. There's 4 rows of 60 in each horn, to be precise. But they're not a very accurate sign in terms of staging the pregnancy. You can't really say this is 3 months, that's 4. Not as accurate, because they vary in size. Near the fetus, they're going to be much bigger in the very same cow than those that are located in the non-gravid horn. And our final sign is enlargement of the uterine artery. It's number 4 in the diagram that leads to the uterus. As pregnancy progresses and the demand for blood is greater, nutrients, oxygen, and so forth, it enlarges. And we can palpate that. And it's fun to palpate that because it develops a flow pattern, some vibration in the artery called fremitus, a Latin term for turbulence in that artery. And again, there's a scale that I suppose the specialist memorizes, which is that at 3 months it's 3 millimeters. The first we can start picking it up. And it increases 3 millimeters every month after that. So it's 3 at 3, 6 at 4, 9 at 5, and 12 at 6. And after that, we can start feeling the artery on the opposite side as well, the non-gravid side. It gets big enough to participate. But what's really characteristic is the blood flow, the fremitus, in this artery. And all along, we palpate the fetus, and at about 7 months, the fetus will be big enough that you can pat it on the head, or you can feel its feet. Now, pregnancy can also be diagnosed with the use of ultrasonography, but there are some differences with that technique as compared with other species. We cannot do it as early as you can do in the mare, where at a couple of weeks one can already diagnose pregnancy. Not so in the cow, not so in ruminants. The reason for that is the fetal membranes in the ruminant are filamentous. It's a cotyledonary placenta that spreads out throughout the entire lumen of the uterus, and as such the diameter is smaller, and one has to wait longer for it to be large enough to pick it up. The earliest we can do this with ultrasonography is probably about day 26. Let's say 4 weeks, 28 days. Well, with our fingers, an experienced palpator can pick up pregnancy as early as 30 days in a heifer and as early as 35 days in the cow. Not a great deal of difference. But ultrasonography can do something palpation cannot. It can detect a heartbeat, and ultrasonography can be used to sex the fetus from about day 55 to day 85. It's a nice window to examine the fetus for a genital tubercle. In the case of the male tubercle, this is located just posterior to the attachment of the umbilical cord, where the prepuce would be. And in the female, this genital tubercle is located below the base of the tail. And with some effort, one can see that, not necessarily in this picture, but one can see the base of the tail and the location of the tubercle. So that's a very nice thing where ultrasonography is more precise. Use of the ultrasound unit on the farm requires portability. It requires shade in the area. We can't have sunlight directly on the screen. And these units tend to be fairly expensive, but that's likely to change as they become more commonly used. Well, we have diagnosed the cow pregnant, and we need to be concerned about delivering the calf. A lot can happen in between time. For the sake of time, I not covered things like abortion, various diseases, be they viruses, bacteria, protozoa, and even fungi that can cause abortion at different stages of gestation. And a number of accidents of gestation can occur. We can have mummification of the fetus. We can have maceration, just bones that remain after an incomplete abortion, incomplete expulsion. Such things as torsion of the uterus can occur. Closer to parturition, we have sometimes prolapse of the vagina when estrogen levels rise. Lots of things that can go wrong with the pregnancy and require our attention. But I want to turn our attention to obstetrics and point out that there are two basic problems. And one is that owners get very excited when a cow goes into labor, a foot appears, they latch onto it and start to pull, and pull harder. Maybe with the pickup truck, maybe with the horse or with a swinging gait. It's terrible what sometimes is done kind of in a panic and with very poor judgment. And the second one is improper hygiene. As you see this cow lying in a muddy pen during the raining season. But there are ready solutions for that. We can have a pasture with shade and no standing water, preferably. And it's no accident that beef cattle have fewer problems with hygiene and the results of poor hygiene, uterine infections and so forth, than do dairy cattle. On dairy farms, we can have maternity pens that are easy to clean with large swinging gates so tractors can get in there and keep it clean. Otherwise, we get a buildup of bacteria and contamination that would make it actually worse. Well, we need to examine the animal once it goes into estrus to determine a number of things, really. That, first of all, the cervix is fully dilated. You should actually not be able to feel it anymore. It should have melted into the wall of the vagina. And the condition of the fetus, whether it's alive or not, is important to know. And we need to know its presentation, position, and posture. Presentation can be anterior longitudinal, or it can be posterior longitudinal, whether it comes head first or tail first. The position refers to the orientation of the back of the calf, the dorsum of the calf, and the four quadrants of the maternal pelvis. So we can have the most common position, which would be dorsosacral, the back up, so right side up, dorsosacral. Should the fetus be upside down, then it is dorsopubic, or it can be on its side, in which case it's dorso-left ilial or dorso-right ilial, depending which ilium of the cow is involved. So that's determined, and we need to know if there's adequate room. Let me first look briefly at some causes of dystocia, and by far the most common one is disproportion of the fetus and the pelvis. The fetus is just too big for the birth canal, or conversely, the pelvis is too small for the calf, or both. Second is abnormal posture. Posture refers to the relationship of the extremities of the fetus, including the head and neck, to the fetus's own body. To be lined up correctly, the limbs should be extended, and so should the head and the neck be. If that's not the case, the fetus becomes too large in diameter to come through the birth canal, and this has to be corrected. Correction is usually by repelling the calf, pushing the calf back into the abdomen, and retrieving the leg, in this case the left leg, that is retained at the shoulder. Or, a second example, the calf here in the anterior longitudinal presentation, the position is dorsosacral, and the posture is head retained to the left. These are not uncommon, usually seen when the calf is dead and the calf does not participate in its own delivery by keeping its neck and head extended, or weak calves that are unable to do that. The remedy then again is pushing the calf back in and straightening out the head. If we cannot do that and the calf is dead, then we can, with the use of the fetotome, we can and deliver it separately. Another cause is twins. Twinning occurs probably 1.5% to 2% of the time in dairy cattle, a bit less in beef cattle, 0.5%. But they can cause dystocias because both calves may want to come out at the same time. And sometimes a herdsman will put ropes or chains on legs belonging to two different individuals and try to pull them both at the same time. I like twins. I like taking students on a puzzle like this. That's what they are, figuring out which leg belongs to what individual, and then repelling one somewhat and extracting the other. I would, in this situation that's depicted here, I would repel the head and pull the posteriorly presented one first after making sure both legs are there. And then some rare conditions here, monsters, rare indeed, but here's a calf that has 5 legs and it has 2 heads. This calf has pretty long hair. It's mature, and it's made it to term, but it is not so heavy, but as it is large, so it has strange proportions. It cannot come through the birth canal. These calves then need to be delivered by fetotomy, But we cannot do this as long as the calf is alive, so we may have to pull the umbilical cord to euthanize the calf and then proceed and cut off one head or both heads to cut it down to deliverable size. One other example would be a calf with a hydrocephalic head. Don't have a picture here right handy, but that's another occurrence that we see once or twice a year. Those also should be delivered by fetotomy, even though the calf overall isn't large. The head is rather large, like a soccer ball, too big. A head like that needs to be deflated. You can insert a needle, and you can then drain the head, and as it collapses, it's not difficult to extract the rest of the calf. Well, all of this needs to be done according to a plan, and here is a plan that indicates that calving usually is spontaneous, but if it is interrupted, if there is a delay, we have to check the presentation, position, and posture to make sure it's all lined up properly. And if it is not, if the head is retained, we correct that, and after it's been corrected, we apply guidelines. If the guidelines tells us that there is enough room, we can extract it, give it added pull, but sometimes we run into trouble with the hips of the fetus locking up with the maternal pelvis, and then we're in a dilemma. If the calf is alive, we tend to pull harder, even harder than we would feel comfortable with. But if the calf is dead, we do a partial fetotomy. Partial meaning we cut off the exposed portion of the calf, probably as much as the anterior 2/3 of the calf, and then we place a wire around the calf between the legs and dividing the fetal pelvis and removing those two pieces separately. Now, how do we tell whether the calf can make it through the pelvis? And in this diagram, you were really looking down on the calf. We put a rope or a chain on one of the legs, and an assistant will pull that leg until it extends 15 centimeters. That's just about the width of the average hand and thumb outside the vulva. If the pastern can stick that far outside the vulva, the shoulder, the left shoulder of this calf, will have passed the iliac shaft. The pelvic inlet with the iliac shaft is the narrowest portion of the birth canal, and it's bony, so it doesn't give. Well, that leg has gone far enough that the shoulder has passed. Now, if a second person can pull the second leg, the right leg in this diagram, equally far, also 15 centimeters outside the vulva, then we know both shoulders have passed the iliac shafts. And it means that the calf can make it. It's a decision we can make in a matter of minutes before we just start to pull indiscriminately. And believe those guidelines that if it doesn't come, it's too big, we have to go to either a fetotomy or we have to go to a C-section. Let me make a comment on the pelvis of the cow. As you can see here clearly, the diameter of the pelvis is kind of egg-shaped. It's taller than it is wide. Now, if I show you the cross-section of the calf, you'll notice that, and this is a calf I had, a dead calf I froze. I hung it by the hind legs in the cooler, in the freezer, and then cut across the hips. And you can see the greater trochanters of the hip joints there. And notice that they are wider than this calf is tall. Don't be misled by the legs, the muscle of the thigh. That can compress and is not. But the calf is wider than it is tall. That is just opposite from the cow. It's taller than wide. And when I put the two together here, the calf cannot pass through the iliac shafts. The solution is pretty obvious, and here it is. We rotate the calf. Now, normally, unassisted delivery out in pasture, that does not have to be done, but we get to assist those calves that won't make progress, and those are the ones that, by rotating the calf, can just be delivered per vaginum rather than having to do a cesarean section. And as I said, if extraction is not possible, we've decided it doesn't measure, then we have these two options: fetotomy if it's dead, cesarean section when it's alive. Okay, we've made the decision that the calf can be delivered vaginally. We now prepare for delivery, and one of the first things I do is washing her up thoroughly with soap and wash the arms and hands. The two cardinal guidelines of obstetrics are cleanliness and lubrication. Work as clean as possible and use a lot of lubrication. If an animal has been in labor for some time, all that lubrication, which is amniotic fluid, has been squeezed out and then is lost for lubrication. So we have to replace that. The best lubricant you can use for prolonged procedures is Vaseline. The worst thing you can use is detergent. Joy for dishes is terrible for obstetrics because it degreases, it defats, it makes things squeaky clean, if you will, and we don't want it squeaky clean. We want it slippery and slidey. Squeaky clean means that there is friction that leads to irritation, and that leads to swelling, and that leads to pain. So use lots of lubrication, and then we put the animal down because there's some other advantages to that. The cow, as she lies down, and this is the way she delivers her calf most of the time. Cows don't deliver calves standing up very often. She can now angle her hind legs forward, and that tilts the pelvis and gives a greater angle, a little extra space. Also, if you imagine for a moment the cow standing and the calf has to be delivered, it has to come from the floor of the abdomen and it has to climb up out of the uterus through the birth canal. Whereas when the cow lies on her side, she can, this calf can come out sideways, parallel to the ground. And by laying the cow down, we can do that with a couple half hitches and a long rope and pull them to the ground. We can lay her down in a spot that's convenient to us, and that gives us enough room to work behind the animal, where the people that pull the calf can sit down and pull with arms and legs at the same time. So we task the cow. Now, a quick sequence on how we can rotate this calf to get the fetal hips through the birth canal at a slight angle. As soon as the head of the calf is delivered, the operator, who is sitting on his knees or her knees behind the cow next to the udder of the cow, will stick one arm, the right arm of this individual, all the way underneath the calf, the head and the legs, and the left arm, the second arm, between the front legs, and then the fingers are folded in a prayerful position, if you will, and then the head is pulled towards the knees of the operator. And that will twist the calf, and he pulls as hard as he can, not trying to go exactly 45 degrees or 90, just as much because as he can, because the body is limp and will twist while the hips don't go with it initially. Then he gives orders to the people on the ropes to pull whenever the cow is straining, and do that in unison. There is no panic. Again, the cow is such a nice model for this to teach obstetrics, because you can be in there with two arms feeling where things are, and there is no panic, no hurry. The umbilical cord is still attached, so the calf is oxygenated if it's in an anterior presentation. And we can take our time. We can rest in between, the cow can rest. So he tells when to pull, and when the hips have passed the iliac shafts, they still get retarded, if you will, slowed down by the lips of the vulva and by the vulvovaginal sphincter, the area of the hymen or remnants of the hymenal area. Especially in a first calf heifer, they have never been stretched that much, and they will offer resistance. So the lips of the vulva in that area has to be worked over the hips, as is being done in this illustration. Once the calf is out, we immediately turn our attention to the calf and establish breathing. It's best to set a calf on its chest, as is shown here, so the chest can expand in both directions, versus lying down flat on one side where only the upper side can come up. The least resistance by setting them up like this. And we should clear the nostrils, and we should pull the tongue out, have the head and neck relatively straight and no impediments to airflow. Now, it's common practice on some farms to suspend calves by the hind legs, even to swing them, with the object of expelling fluid from the lungs. But I think that's mistaken, and it's contraindicated because there is no fluid in the lungs. The lungs of a fetus are consolidated. They are hepatized. Like liver, there is no air in there. So there is no fluid in there. There's a little bit of fluid in the trachea, but not in the lungs. So when they say, well, hang them up and look at all the mucus coming out, what they're looking at is amniotic fluid, mucoid, coming out of the stomach of the calf. So it's not helpful to suspend them. In fact, it hinders the calf. If you think of the diaphragm of this calf here, the diaphragm is like a little hammock, and in that hammock lie the viscera, the intestines and the liver, pressed down on this little fetal lung that has never expanded before and now has to expand against all that weight, making it much harder instead of helpful. We've made sure the calf is breathing. What we do next is to go back to the cow and check for the presence of a twin. And when we get the twin out, we get it to breathe and go back in and check for a triplet. I've delivered several sets of triplets over the years. I've even delivered a set of quadruplets once that were all alive at term. So you keep going back in until there are no more calves. Then we turn our attention to the cow. We give her oxytocin. The idea is to continue contracting that uterus. She's probably tired after dystocia, so she needs some assistance there. And it causes milk letdown, which makes a good opportunity to check the udder for the presence of colostrum, blind teats, mastitis, and things like that. We also check for trauma in the birth canal. The calf should be given colostrum. In beef cattle, we usually let them nurse. In dairy cattle, that's up to the individual farm. It is important that they get about 8-10% of their body weight in colostrum within the first 12 hours. Preferably, really, within the first 2 hours before closure takes place of the gut. And it's amazing that a big calf, if it weighed 50 kilos, it can drink 4 liters of colostrum all in one setting. It may not wish to drink that, but you can give it with an esophageal feeder to make sure it has obtained its full dose. We should use a colostrometer to measure the immunoglobulin content of the colostrum to assure that. Well, the postpartum period, or the puerperium sometimes called, is a very critical time in the life of this transition cow, tremendous changes take place, and there are things that can happen immediately after calving, such as prolapse of the uterus. This happens in cows that have very poor uterine tone, say as a result of hypocalcemia, the most common predisposing factor, and it can come out very, very rapidly. I will never forget going to a farm with a group of students, a cow that wasn't making much progress in delivering her calf. We assisted it, pulled the calf, and fussed over, getting it to breathe. When the cow behind us, and she was lying on a little slope behind us, coughed once and suddenly pushed the entire uterus out. In just one cough, essentially it came out. We almost panicked. The girls shrieked, but we put it right back in because it was limp and it was very easy to put right back in. Once they've been out for a little bit, then they get firm, and it isn't always easy to replace. Here you see a cow, if they can stand, it's best to have them stand, wash the uterus off, give epidural anesthesia, as I've indicated here in the notes, and replace it. Once it has been replaced, it we have to make sure that the horns are back totally inverted. It may be necessary to run in 10, 15 liters of water to make sure the horns are inverted again. And with the follow-up treatment, which is oxytocin, the uterus will contract and get rid of the water. And by giving it calcium intravenously, muscle tone is restored, and this firm uterus is not going to ooze back out and prolapse again. Therefore, it's not necessary to place retention sutures or prolapse pins, something of that nature. That is in contrast, if I can sidetrack for a moment, with a cow that has a prolapsed vagina. Prolapse of the vagina occurs typically before calving, when estrogens from the placenta go up and things get relaxed, and the big calf is pressing on the vagina, it pushes it out. And once it's outside in the air, it will dry out, become irritated, and more becomes prolapsed in those cases. The prolapsed vagina also has to be replaced under epidural anesthesia, but it must be retained. It will not go far enough forward into the abdominal cavity to stay in there, and we have to retain them with prolapse pins or a lacing type pattern. Well, the next thing that we have to be concerned about is retention of the fetal membranes. The definition is if they have not been delivered within 12 hours, we consider them retained. It's not a rare occurrence. Up to 5% is almost considered normal, but it can be up to 10 or 20%. Retention of the membranes is associated with early delivery. A cow having twins that delivers 10 days, 2 weeks early, often will have retained placenta, or after a dystocia. Or it can have nutritional components, say selenium deficiency, vitamin A deficiency, all are reasons leading sometimes to retention of the placenta. It's not a life-threatening thing as it is in mares, but it does need attention, and we need to monitor these cows that they are eating properly, not running a fever, and that their milk production is up to par. If any of those are out of line or abnormal, then we institute systemic antibiotics. We gave our cows that we assisted oxytocin, we talked about earlier. That's not a bad practice. Oxytocin is very inexpensive. 50 units of that will go a long ways, and studies have shown that it'll aid in prevention and of retained fetal membranes and lowering the incidence. Then, following retained fetal membranes, quite often the cow ends up with a metritis, delayed involution, That's also the case after contamination and trauma following parturition. Most meatritises are the result of improper obstetrical techniques or dirty environments and so forth. The cow deals with that pretty well depending what the organisms are. If they're toxin producers, we can have toxic meatritis, and that is a serious problem. If they are the barnyard organisms, they're still in an aerobic environment as the uterus is open, the cow handles that pretty well. In fact, if you were to culture uteri a week after parturition, probably 85% of them would show signs of infection. You could recover bacteria. So treatment is just careful watching, and then if they get sick, we need to treat them. There will be discharges. We can palpate them and make our diagnosis on that basis. If a cow has other problems, metabolic problems, mastitis, and so forth, this frequently leads to a delay in involution, and secondarily, meatritis becomes part of the picture. There's one special type of uterine disorder, and that is pyometra. A little bit later, after parturition, when the cervix closes and the animal starts to cycle again, it is possible for the infection to be trapped in the uterus, and we now are dealing with a pyometra. Quite different from pyometra in other species, specifically the dog. The cow is not sick with a pyometra, and she's also not cycling. She thinks she's pregnant. There's enough destruction of the endometrium that the prostaglandin is not released into the bloodstream to cause regression of the corpus luteum as it should by countercurrent flow. So the corpus luteum is maintained and the cow does not show estrus. And these cows go undetected until somebody palpates them. The good news is that the treatment is relatively simple. We can give these cows some prostaglandin F2 alpha, 25 milligrams, but it is best to give a couple injections because the corpus luteum is very well embedded, and a single injection may not last long enough to get full regression and ischemia of the corpus luteum. Follow-up care to these is not required. They need to be examined again that the uterus has involuted, but that's usually sufficient. We do not use antibiotics for these cases. We do have to skip a couple cycles until the damage to the endometrium has healed and before the uterus is in shape, in condition to become gravid again. It can also be diagnosed with ultrasonography. That's a fun thing to do. You see all this fluid, and there's flocculations in it versus the clear fluid we see inside follicles or inside the bladder for that matter. But you don't need ultrasound for that. You can do that by palpation quite readily. Other disorders are adhesions. You see an ovary, and that's the one that's most seriously affected by adhesions, but the uterus may also be stuck to the floor of the pelvis, or the horns stuck to each other, and ovary stuck. Adhesions can be cause for sterility if they are severe enough. If they involve the ovary, then we may end up, the cow will end up with salpingitis. A word or two about ovarian problems. I list inactive ovaries first, whether that's a disease or not, but it's a symptom probably of low energy level, and we see it for that reason most commonly in heifers, first calf heifers that are producing a lot of milk and don't have the extra energy. Treatment is to increase the energy level, and as soon as they stop losing weight, they will resume cycling. There is no hormonal treatment to get these cows to cycle. Cysts are relatively common. Follicular cyst, as the cow tries to resume a cyclic pattern, may occur, and they are the result of failure to ovulate. There is no LH peak, and maybe the LH peak is suppressed by the stress of the postpartum period. We see them most commonly between day 15 and day 45 postpartum. There are two types: follicular cysts with thin walls, and the ultrasound shows that very nicely how large, distended, and thin-walled the cyst is. And the other kind is a luteal cyst, where the cyst is trying to luteinize, trying to turn into a corpus luteum, lays down a little bit of luteal tissue, and becomes thicker walled. And you can feel that by with your fingers by palpation, and you can, of course, visualize it very nicely with ultrasonography. As far as treatment is concerned, it doesn't matter whether it's follicular or luteal. If it's a luteal cyst and you are sure of that, you can treat them with prostaglandin and regress that luteal tissue, or take them through the whole treatment, which I will show in just a minute. One differential diagnosis is that hollow corpus luteum I spoke about, the cystic corpus luteum that may feel like a cyst and may even look a little bit like a cyst with ultrasonography, but which is a normal structure and doesn't require treatment. And cows with hollow corpus cystic corpus luteum, cycle normally, whereas cows with cysts do not. They are in heat a great deal of the time, frequently, off and on, or they are anestrus. That's also part of the syndrome. Here's the treatment protocol. This is actually a synchronization of ovulation type protocol we use for breeding management purposes, but it works very nicely with cysts. The basic treatment for cysts is the administration of GnRH to release LH, or we could give LH directly, but GnRH is less expensive. And if we follow that treatment a week later with prostaglandin, we will regress the luteal tissue that we have produced with the LH the week before. What happens on day 0 with the LH that is released, we will cause luteinization of the cyst, or we cause ovulation of a follicle that happens to be present on the ovary. A week later, when we give the prostaglandin, all that luteal tissue is regressed, and a new follicular wave starts. And we give that a couple of days for a dominant follicle to come up ready to ovulate, and we give 2 days later a second injection of GnRH to cause the ovulation of that follicle, and 16 hours later we inseminate that. You should remember that the interval between the LH peak and ovulation in the cow is 24 to 30 hours. So we give this at 5 o'clock in the afternoon. She will ovulate a day later. In the meantime, we'll put semen in there 16 hours after injection, waiting for the egg, the oocyte, to be released. That works with the cysts very, very nicely. Finally, a couple quick comments about assisted reproductive technology. Again, the cow is such a wonderful model. We've done artificial insemination commercially for years now, and we have the technique of freezing semen and shipping it all around the world for import, export, and so forth. So I will not comment too much about artificial insemination. In North America, this has fallen into the hands of technicians primarily, but as veterinarians, we need to monitor the program from time to time, that they use proper thawing procedures, that they thaw the semen close enough to the cow, and use clean techniques to inseminate. We may even have to teach inseminations refresher courses from time to time, but that's a very well established thing. I'd like to make a few comments on embryo transfer. I'm looking at this picture with you of a litter of limousine calves out of this limousine heifer way back in 1972 when all of embryo transfer was done surgically. We've come a long ways, and now it is an accepted commercial practice, requiring a lot of guidance and treatment, quite a few carefully orchestrated steps. And one of the first ones is the donor selection, usually done by an owner who has a elite cow, great genetic merit, or a favorite cow. That happens almost too often. One that they can't get pregnant anymore is now old and say, let's get some calves with embryo transfer. Well, that type of a donor is not the ideal donor. But what the owner considers a good donor might be different from what I consider a good donor. I need a cow that is reproductively healthy, has a good history of regular calving, and I find no adhesions and no abnormal structures. Second step then is to superovulate this cow. Instead of flushing one embryo at a time, we're able in cows to treat them with hormones, follicular stimulating hormone, to get several ovulations. And FSH has a rather short half-life, so we have to give that repeatedly, morning and evening, over a period of 4 days. The best time to start this protocol is in the middle of the cycle, let me say day 10, because we're between dominant follicles, and as we are trying to recruit follicles for ovulation, we don't want that dominant influence there, but rather a whole group, a cohort of follicles at once. So we stimulate those by injections. It's in the middle of the cycle, so the corpus luteum is there, and we need to also schedule regression of that corpus luteum, which we do at the time of the fifth injection. That would be the morning of the third day. We regress the corpus luteum, and now these follicles are free to burst into development. As the progesterone is removed, the brakes are off, and a whole group of follicles will ovulate. But first, they will produce estrogen and bring the cow into estrus. We then inseminate the cow and get fertilization of quite a few at one time. Then comes the embryo recovery. This is done on day 7, a week after insemination, and done non-surgically today with a catheter that is introduced through the cervix, much like an AI pipette. But then once it is in there, it's a balloon catheter. The balloon is inflated to block the outflow of fluid, which we introduce with a piece of tubing into the uterus. So we run physiological saline that has been buffered. That's PBS, phosphate buffered saline. We run into the uterus under gravity flow, probably about 75 to 100 cc's at a time. And we can regulate the flow with clamps on the tubing. So we distend the uterus, shut off the inflow, open the outflow, and run it through a little filter to concentrate the fluids. Typically, we would use a liter of sterile fluid that's been warmed to body temperature and run it through the filter to reduce the volume, but trapping the embryos in the filter. Then the filter is taken to the laboratory and poured in a dish that can be searched, and the embryos are selected. We see here a little chart of embryos. There's a 4-cell embryo that you probably would see on day 3 of her cycle, and then progressively those 4 cells, which we call blastomeres, will divide, and each next generation of cells is half the size of the parent cell. So they get smaller and smaller to where in the second row you can no longer see individual cells. They're so compacted. This is a morula. It's a compact morula, which we see on day 6. And at that time, a small cavity forms within the embryo, fills with fluid, and you can see the embryo right next to it in the second row. That is a blastocyst. That is day 7, and that's the time on which we recover the embryos. We need at the same time to be concerned about lining up recipients. They can be from various sources. It's expensive to maintain a large pool of them, so we may want to transfer the embryos from the best cows in the herd to the, genetically speaking, the poorer cows in the herd, but not as poor as in this picture where we see a lot of low body score cows. The recipients should be healthy, in good body condition, and they should be cycling, because we must manipulate their cycle to synchronize their cycle with the embryo, with the donor. We collect the embryo day 7, so these recipients receive it on day 7 through the similar hormonal environment of the uterus. Not a good idea to go to a sale barn and pick up a bunch of culls for this purpose. Then we need to transfer this embryo on day 7, as I mentioned. At that time, the recipient will have a corpus luteum, which you can palpate, and then the embryo has to be placed on the side of the corpus luteum at the point indicated in the picture. Is a little cutaway showing the tip of the catheter, but deep into the horn, I say at the external bifurcation, which is at the level of the intercorneal ligament, as you can see. This has to be done atraumatically, and it has to be done in a sanitary fashion, because the uterus at day 7 is under progestational influence and much more susceptible to infection than it is during insemination during estrus. That requires extra skill, and I think and would hope that this can stay within the purview of the veterinarian versus being done on the farm, which is not to say that technicians can't be trained to do that, but they do require additional training to identify the corpus luteum and to observe the special technique. In vitro fertilization, only a comment or two. Our involvement as veterinarians is, again, crucial at the beginning and at the end, but it's largely a laboratory procedure where the eggs are matured in the laboratory and fertilized and cultured. But we are involved in the collection of the oocytes, or can be. Many oocytes are collected at the slaughterhouse. That's fine, except genetically they're totally unknown ones, even as far as the breed is concerned. But for research, that's been an excellent way to learn the techniques and test a number of hypotheses. Or they can be collected directly from the donor, from the live donor, with ultrasound and a needle guide. For that, we use a vaginal probe, a sector scanner with a needle guide, and we can visualize the follicles on the screen and then insert the needle directly in the follicle and with a suction pump aspirate those. It's a real challenge to do that, to learn that. It's also fun to do. Then these go to the laboratory in which they are evaluated and selected and matured. Once they are mature, they're combined with sperm, which also is special treated with a PERCOL swim-up protocol, and then fertilization in vitro takes place. One straw of semen can fertilize a lot of embryos, even though the semen would be extremely expensive. As we want to use elite bulls, it can be used for several eggs at the same time. Embryo culture then is followed. You saw some developmental stages a moment ago in a chart, and the best can be selected for transfer. Recipients have to be ready for that. That has to be coordinated. Or, of course, we can we can freeze embryos, both the in vivo derived or these in vitro derived. But remember that any time we manipulate the embryo, we devitalize it to some extent, and the pregnancy rates following that are going to be lower. To give an example, an in vivo embryo transferred directly may give a 70% pregnancy rate. If we use that same embryo and freeze it first and then thaw it again, we'll probably lose about 15%. We're down to 55% pregnancy rate with that type of an embryo. Finally, a comment about cloning. First, to say that in a way it's nothing new. Identical twins have been around for as long as mankind has been here, and in the animal world as well. We've also made clones by splitting embryos surgically as long as 20 years ago in the laboratory, cutting a blastocyst in half or a morula in half and transferring the individual halves to synchronized recipients. But the more recent technique is nuclear transfer, and even that's not all that new. In cattle, here we come back to the cow being such a nice model. Nuclear transfer is practiced in Texas by the Granada Company. That's no longer in existence. But we have on our faculty in animal science Dr. Karen Moore, who was involved in some of that. By using the technique of nuclear or nucleus transfer, taking the nucleus from a donor animal, a very desirable animal, and take the nucleus and put that into an oocyte from which that nucleus has been removed. So an enucleated oocyte receiving a nucleus from an elite animal. There are lots of sources of these nuclei. Most of the early cloning has been done with embryonic cells, but we've all read about Dolly the sheep in Scotland. She was cloned. One of her mammary cells was cloned. Her mother's mammary cell was cloned, and that led to the development of Dolly. But she was one of many, many attempts. This is not a very efficient technique, but it's improving, and we will hopefully be involved. We need to be involved in the obstetrics, the supervision of calving of these. Unfortunately, with in vitro fertilization, there is a fair percentage of calves that are not normal when they are born. They're large, excessively large, requiring our supervision and the need for C-sections and so forth. Well, this has been a quick overview, some highlights of bovine reproduction, many aspects we probably could and should have visited with, but I look forward to our question and answer session at some future date.